Well, hello, everybody. Live human beings, folks on Zoom. Thank you for joining. Really excited today to announce our distinguished speaker series guest, Dr. Palamar. Did I pronounce it right? Palamar? Okay. Yeah. I just call him Joey because. Before I get started, for those of you who don't know about our institute, we are an interdisciplinary academic unit at USC, and our mission is to advance collaborative, transdisciplinary science, education, and community engagement, including a forthcoming Masters of Addiction Science program that will be starting this fall. So please spread the word. It's a really cool interdisciplinary program that's a collaboration of the schools of social work, medicine, and pharmacy. So anyhow, check it out at ias.usc.edu. And also I'd like to thank our sponsors, as always, who support the Institute. So that includes the Department of Population and Public Health Sciences at the Keck School of Medicine, the Keck School of Medicine's Dean's Office. We've got the Norris Comprehensive Cancer Center, the Mann School of Pharmacy at USC, and the Doric Peck School of Social Work at USC. Okay, so we're very interdisciplinary, a lot of people to thank. So let me go ahead and get to our speaker, Dr. Palamar. So I was really excited that he agreed to come all the way from New York. He does timely, cutting edge research. So let me tell you a little bit about his background, and then I'll go into a little bit about his kind of research areas. So he has 2 undergraduate degrees in criminal justice and forensic psychology, which I thought was cool. And a master's in educational psychology from NYU, and then also an MPH from NYU and a PhD in public health from NYU. And I think ever since, he's been a faculty member there in various parts of NYU. Most recently, so he's risen the ranks. He's now an associate professor, and most recently, and for the past several years, he's been in the Department of Population Health there. So his research is really interesting because anytime it seems like that if there's like an interesting kind of new cutting edge topic in drug use epidemiology, Joey is one of the first people to actually have data to come out and address it. And so he addresses a lot of important timely topics. One of them was, I remember addressing when there was more cannabis legalization. One question is whether the older adults and baby boomers would kind of like return back to cannabis. So he had one of the first studies on that. I think a lot of stuff about opioids, much earlier in the research trajectory. Also, a couple things that's important about Joey's work is that he addresses lesser known substances, or I should say understudied substances, which are really important in addiction science, and we just don't have enough data on them. And so that includes bath salts, also the synthetic cannabinoids, ketamine, which of course now is of increased interest because of therapeutic use, kratom. So really, really great innovative stuff. And then the other kind of layer, I think, which I really appreciate about his research is it's methodologically rigorous. And so he's done some really interesting work to identify what are the optimal ways to track drug use epidemiology, including in dance clubs. Also kind of validating survey items. Interesting work because we often use kind of labels like ecstasy or Molly. So do the actual people using the drugs know what we mean? And then some interesting biomarker stuff too. So, and I think the other thing to note is his research is widely disseminated. Washington Post, the Today Show, his work is really, really impactful. So let's give him a warm welcome, Dr. Palamar.
It's the nicest welcome.
I'm sure. Well, thank you. You traveled 3,000 miles. You deserve it.
I'm still in New York time. By the way, how do I change slides? Do I
Just go ahead and use the mouse or the right person. Click the background once.
And
Okay.
we'll do Q&A at the end. If the folks on Zoom want to start logging questions, that's fine. But we'll wait till the end.
So when do I have until 1 or because we started late?
Yeah, you just do your thing, some people may leave at 1 and others will hang out.
Okay. All right. Well, thanks again. And thanks for having me here. So today I'm going to talk about seizure data with regard to fentanyl use. We need a lot more seizure data, a lot more data with regard to fentanyl, because obviously we're in the middle of a crisis and it doesn't seem to be getting any better right now. First thing I want to talk about for a few minutes is the common national data sets that we use, or national data sources in the US, which may or may not monitor fentanyl use. So we've all seen this probably a million times, one version or another. Of course, they left off at 2019. It's very hard to get updated graphs from the CDC. But the main point of this is that synthetic opioid deaths have been skyrocketing compared to other drugs over recent years. If we got newer data, that would go even higher, sadly. But these are deaths. Deaths, obviously, it's one of the most serious outcomes related to pretty much anything. But with regard to opioids also. But a main point I want to make is that death trends do not equal trends in use. A lot of times we focus solely on the death data, which obviously are the most important. But what about the people who are at risk for death, or at risk for poisoning or anything else? So I want to talk about mortality and morbidity data quickly. So that's mortality data, the CDC data. Obviously, again, deaths are most important. But these are the most serious outcomes. It doesn't reflect who just uses, who had a non-fatal overdose. That's something we don't focus on enough at all, non-fatal overdose or poisonings, however that's defined. And another thing is when somebody dies, we cannot interview them. We don't know what their intentions were. Did they know they were using fentanyl? What were they co-using? Well, we could determine that through talks mostly, but what were their intentions? With regard to morbidity data, poison control is a big source. Poison control is something I focused on a lot. There are positives and negatives to everything. A big positive with regard to this is we get to look at non-fatal overdoses regarding fentanyl. But a big negative is that only a very small percentage of people who are poisoned or exposed to fentanyl have their data reported to poison control nationally or locally. So that's an issue. But the people who do survive, we pick up data on what they co-used, on how they used, what their intentions were, for example, suicide attempts. We don't get that information from death data. And then there's hospitalization and other emergency department data. I guess I'm much older than most people, but a lot of us, some of us might remember the Dawn data. That went on through 2011. That was a good source of hospitalization data. They stopped functioning for about a decade or so. They recently put themselves back together. They've been collecting data the past year or two, but their reports only focus on a handful of drugs. I was just looking for updated ketamine data the other day. There's nothing. So I hope that this becomes another major source, but either way, that will be lagged data, even if it does become another source. Survey data is like the big one for most of us, I think. Even if we look at tox data, what it's still surveys, I think everybody in this room, that's our stuff. So NDEWS, the national survey, this is like the leading drug survey since the 1970s. It has to change its name, but it's the same situation. There are two major flaws in this survey with regard to what I'm talking about today. The first is people who are homeless are extremely underrepresented here. And therefore, a lot of drugs like fentanyl use would be severely underrepresented because of the breakdown. But another thing is they don't ask about fentanyl. So right there, it's useless for what I'm talking about today. They ask about non-medical or fentanyl misuse, but that's prescribed use. They don't ask about it, surprisingly, or if you're used to analyzing this data, I guess not surprisingly, because they're always about 10 years behind. Monitoring the future is the other leading national one. They at least add new drugs in closer to real time. They actually added a fentanyl question on one of the 6 survey forms about 2 years ago. The problem is it's only a 1/6 of the high school sample that is asked about past year fentanyl use. I have acquired these data, even collapsing multiple years. I can't even run a simple chi-square with only a handful of people that have been asked about reported fentanyl use. So again, another, we're lacking proper surveys. In other surveys, some might ask about fentanyl, assuming they're doing it in the correct manner, but nothing national, not to my knowledge. So self-report, we don't have very much at all on self-report of fentanyl, which is unbelievable because this crisis has been going on for years and it's getting worse. Seizure data is what I'm mainly, oh, go ahead.
I have a question for you. So, and maybe you can clarify that before you get in, but with fentanyl use, there's sort of 2 issues, right? One is like straight up people intentionally using fentanyl, and then the other is people unintentionally using fentanyl.
Yeah.
And so one of the things I've been like confused about with monitoring the seizure and with some of these other surveys is that they're only getting at really intentional fentanyl use.
Or known use, yeah.
Or known use, but the bigger problem seems to be unintentional fentanyl use, right?
Yeah, well, yeah. So with regard to at least heroin use, like just focusing first on heroin, unintentional was the big thing because a lot of people who use heroin weren't expecting fentanyl, at least a few years ago. Now, I think most people should know it's there. But although a point I want to make is that most people aren't even using heroin anymore. A lot of people go straight to fentanyl. But the other thing is, like, I've been studying the club drugs for a long time. People don't know what they're using. Are they using bath salts? Someone's using vodka without knowing it, think they're using ecstasy. So yes, it's very important to know. But with regard to what you're saying, the people who are using these pills, like an oxy, and they get it off Snapchat, and some kid who's never used a drug before gets fentanyl and dies. That's a big problem. And you're right, we have to try and differentiate between known and unknown exposure. But anyway, with regard to seizure data, which I'll explain in a few minutes, I use it as an indicator of drug availability. When we think of seizure data, if we think of it at all, we're probably thinking of DEA NIFLS data. DEA NIFLS, it's a great source of seizure data, but as I'm going to explain in a couple of minutes, it's very limited. So HIDA seizure data, this is what I've been focusing on. So HIDA is the high intensity drug trafficking areas. A lot of people have never heard of it. I didn't hear about it until about 2 years ago. It's created by Congress a couple decades ago, funded by the ONDCP. It was created to assist the federal, state, local, tribal law enforcement agencies, anything determined to be a critical drug trafficking region. And there are 33 HIDAs throughout the United States, covers all 50 states and DC, and even other areas. I think I've seen Puerto Rico, Virgin Islands listed, but I focus just solely on the proper US. It was put together to disrupt and dismantle drug trafficking organizations. And I mean, that's what it's there for, and to simply remove drugs from the streets. So that's something we sometimes forget about with research, especially seizure data. Yes, we want the data, but we're lucky if we get any. That's not why they exist. They exist to try to remove drugs, not to give researchers their data. It seems like at times, well, HIDA cares, but DEA, I don't know. So HIDA versus DEA, I think it was important to put this together because whenever I submit a paper, I'm asked questions like this. So I hope this font is not too small, but anyway, data lag. DEA NIFLS has easily a publication lag of over a year. Their most recent report came out, I think 3 months ago or so. HIDA, they don't really publish very well disseminated reports, at least not yet, but the data are at least available pretty quickly now, as I'll get into. Availability of data to the public, the second row, DEA data rarely available. Even with the Freedom of Information Act, it's very, very difficult to get any data on seizures from the DEA. And if so, it might be like 5 years old and it's not very worth it very much. We could get case level HIDA data pretty quickly. I've been analyzing 2022 full ketamine and psilocybin seizure data now for a few months. I mean, I got the preliminary data in early January. Final data will be in a few weeks, but you can now you could fill out an application online and acquire the data. Geographic, DEA data, typically national only. You might see a report here and there that focuses on state level, but it's almost always full US. HIDA data, we can focus national, state, county level, whatever you want. It's pretty simple, straightforward. Purity data, DEA does have better purity data for labs that actually give a breakdown on purity. We don't really have that with HIDA, unfortunately. And fentanyl data, HIDA, DEA focuses specifically on various analogs, which is great. But for HIDA, one of the limitations of everything I'm covering today is just fentanyl is fentanyls. It's all together in one category. I just like to think that, you know, most of them are potentially dangerous. Yes, some analogs are not as strong as fentanyl. In my experience, most are actually stronger, especially drugs like carfentanil. Anyway, I'm here in part to present about NDEWS, which is the National Early Drug Warning System funded by NIDA. This is how I acquire the HIDA data. And it's a replacement of the longstanding community epidemiology work group, if anyone here is old enough to remember that from years ago. The first iteration was belonged to the University of Maryland for about 5 years. And we took over the second iteration. It's led by Dr. Linda Kotler at the University of Florida. I'm a co-I on the project. I'm very proud to be part of this project. So our main reason for existing is to monitor trends in novel psychoactive drugs and other drugs. Fentanyl is not really novel, but it has definitely reemerged in recent years. We track everything from seizures, poisonings, deaths, self-report, biological specimen, and we monitor online discussion of Reddit and other things. So we try and do a lot. These are what we call indicator data. We try and look at as many indicators as we can to try and get a view of what's really going on. Anyway, just jumping into some results. This paper came out almost exactly a year ago, and I think about a day or two after it came out, Adam, you emailed saying, "Oh, we want you to come here and present." I can't believe it's been a year already, but thank you. But this paper was pretty big. We issued dual or possibly triple press release, and we got a lot of media coverage, but we got the coverage because it was very new data at the time. The data were brand new up through late 2021, so very relevant. So here on the left, sorry again, I thought that we'd have bigger screens, but you'll see that on the left, that's the trends in powder seizures. And that, if you add up all 2021, that comes out to over 8,000 separate seizures. That's anything from small seizure to like truckload. And the smaller line at the bottom there is the number of pill seizures. It's much smaller, but you see it's increasing. What I think is most interesting and most important is this here on the right, which is the proportion of pills seized compared to all of them. And you see just back in 2018, it was less than 15%. And then by just about a year ago, it went up to almost a third. So I don't even know what the 2022 data, final data will look like. I suspect that it will be a third or even higher. But now that's a big change, the pill phenomenon. And that's something I'll talk about today more. And trends in the size of seizures. This goes to show you that these are, yes, there are plenty of small seizures, but the seizures are also getting bigger, weighing more. And that's a big problem, especially the pills. I mean, how many pills in 2021 alone? 9.6 million from my last look at this. So that's almost 10 million separate pills. Things are changing. So the seizures are getting bigger and more frequent. This was covered by CBS News. I was happy about this. And we published, some of our numbers, mainstream national news. We got a lot of good coverage on this, which I was happy about. Try and get the word out, especially the whole pill phenomenon. And This is part of the NIDA press release. Nora Volkow has included this slide in some of her talks, including CPDD last year, which we're happy about. So, yeah, we're pushing out our information quickly. And a big part of this is that NIDA is getting us pretty new data. So it's not real time, but it's only slightly lagged, which is important. We don't have that with a lot of data sets. Yeah, I made this a week ago. My New Year's resolution this year was to teach myself R, how to make pretty figures. So sorry if there are a lot of problems with this or if something's wrong. This took me a long time to make, but I'm proud of it, so don't laugh. I'm old, this stuff is difficult. But anyway, if you see here the pink ones on the side, you see that the bar for 2022 is much, much higher. The current estimate for 2022 number of pills seized is over 44 million separate pills. So that is about 288% higher than the previous year, which is a little over 10 million. So 10 million is a lot. Now it's getting bigger. Again, preliminary numbers, I don't have the final yet. And here, this is the powder seizures. And you see that the powder seizures also increased the amount of seizure over of fentanyl overall. So it's getting worse every year. It's going up much, much higher. The newer data are going to continue to suggest increases. The DEA categorizes things a little differently. Yes, they report weight, but they tend to report in terms of submissions. Submissions can mean different things. Like a submission could be in a gram or maybe like a pack of fentanyl. It's kind of hard to figure out what exactly they're talking about. I talk about how many seizures, how many kilograms or pounds, just straightforward. It's very complicated to interpret DEA data, but their numbers are very high also for 2022. And February 2023, one seizure alone in Phoenix, 4.5 million fentanyl pills in a single seizure. I mean, that's more than was seized in like a whole year just a few years ago in one arrest or one situation. So what is the unique danger of pills in case it's not obvious? Well, right here. So oxycodone, when we think about pills containing fentanyl, typically we're talking about the blues, the M30s. Regardless of whether it's light, dark blue, that is the big one that's even still going around, regardless of the color. They're labeled M30. They look very similar, not identical. But if you're some kid getting a pill and you're not very familiar with what you're getting, you get the wrong pill, it could actually kill you. Or you could be very experienced using heroin or pills or anything that's an opioid, and a very potent pill could really lead to an overdose without you realizing it. Alprazolam or Xanax, yes, they look a little bit different, but these pill presses are enough to really fake somebody out. I mean, me, if I need Xanax, at least I could get it prescribed now. 10 years ago, when I wanted it, my doctor wouldn't give it to me. I don't know why. And if I had to resort to buying it outside somewhere on the street, I might get one of these. And I'm opioid naive. I don't use opioids. I take the wrong pill, it could kill me even at my size. In Adderall, this is another problem. We don't hear about the fake counterfeit Adderall pills that often, but we hear about them sometimes. There's an Adderall shortage in the United States this past year or so. This is a big problem because who takes Adderall? Kids, for them, a lot of teenagers. You don't need someone who's resorting to Snapchat, buying fake Adderall, and it winds up having fentanyl. This is a big, big problem, the pills. And as I mentioned, Snapchat is another problem. You get these young kids, fair enough, people sending like naked pictures, doing whatever. Now, there are advertisements for pills that might contain fentanyl. People are starting to sue Snapchat. I think Congress is doing something. I think a bill was submitted to try and limit Snapchat, but it's still under review. And then we have the rainbow pill, the colored fentanyl pills. This was like the big thing all over the news, particularly before Halloween. Why? Because they look just like those, I think they were called sweet tarts, those little candies. And they do look, this is a real picture disseminated pretty widely of what they look like. And yes, they look just like sweet little candies. And yes, people were worried that people are gonna be like really messed up and give them out as, I guess, a joke to try and kill kids on Halloween. I'm thinking as a kid from the 80s, I was told you go trick or treating, people might put needles or razor blades in your candy. This is a whole nother situation. But was it exaggerated? Well, a lot of the exaggeration came from here, Fox News. I mean, and I watch Fox News, I read about it, and sometimes there's balance, but a lot of times there's not. So I was interviewed and everything I'm going to show you here. I was interviewed a lot about this, but they were pushing really hard saying that fentanyl might wind up in Halloween candy. Even Newsweek was touching on it. Chuck Schumer, in my opinion, he's just as bad as Fox News with some of this stuff. He was pushing it just as hard. It's just the way he is. And he's from New York too. But anyway, BuzzFeed was touching on it a lot. And of course, HuffPost jumped in and was attacking Fox News, pulling my quotes from Fox News and republishing them. It was very strange. And anyway, what happened, to my knowledge, no one got fentanyl pills for Halloween, and I don't think anyone died. I think we would have heard about it immediately. It doesn't mean there's no risk, but it just shows that this is the way the public is really taking things and running with it. And there is a chance. So with regard to potency, the potency of fentanyl in pills is increasing. So there's no set science, but 2 milligrams, I think, is widely considered a potentially deadly dose in an opioid naive person. We can't really find a lot of the evidence, but it's estimated that roughly 2 grams and over 25% of fentanyl seizures are in pill form. So the DEA, which is like the authority seizure-wise on this, they issued this a couple of years ago. 4 out of 10 pills have a potentially lethal dose. So 4 out of 10, that's a lot. But is it? No. A year later, they republished it and just changed the number. Then it turned into 6 out of 10 pills. And what worries me, are they going to update it again next year? Is it going to be 7, 8, 9? So the pills are becoming more dangerous. It's a problem. And my rationale is that my reasoning that it's such a problem is because it's reaching people who would not normally use opioids, who probably have zero tolerance. So what do seizures indicate, or what do we think they indicate? So we got to remember, seizures are intended to disrupt the market. They're not really put there for researchers to just sit at a desk and monitor what's going on. They're there as, as part of law enforcement. So I argue that they indicate drug availability. Other people do too, not perfect. So I have reviewers review my papers. They say, well, if a seizure of 5 million pills happens, then that's 5 million pills fewer that they don't have. But I'm like, yes, but what's happening is the seizures are still increasing. Deaths are correlated with that. The deaths are increasing. Use is probably increasing. They're all correlated. And even in a predictive manner, we could use seizure data to predict next year mortality. We have a paper under review doing it at the county level, and others have done it at a national and state level. So I think it is predicting availability because the way I see it, it's taking a sample of what's out there. Yes, there might be a huge sample that leads to a local drought. I think that happened with heroin in the 70s in some areas, but this is a different situation. Fentanyl, I think I view it as just I'm not part of this, but they are really collecting a sample of what's actually available. So what about indication for modes of use? What could seizure data possibly tell us? Well, I break this down into novices and experienced users. So with regard to novices, people who are just starting out or playing around with opioids, one of the big things we learned less than 10 years ago was that the people who were moving on to heroin largely were using, the regular opioid pills and eventually moved on for whatever reason, whether the supply was taken away or whatever. But a lot of people who use prescription opioid pills pills I'm hearing, I don't have the data, but what I'm hearing from people now is that a lot of these people are just moving on to fentanyl from the pills instead of heroin. It's not pills, then heroin, then fentanyl. Heroin is largely removed. Pills are, I'm also hearing from different people, law enforcement too. They're saying that pills are a drug of choice a lot regarding a lot of different novice users, and possibly because they see a pretty pill. Pills are easier to take. As a club drug researcher, I know a lot of people start off taking ecstasy because it's a cute little pill with a happy face and you swallow it. There's no stigma or concern related to sniffing something. So it's a pill. And injection is no longer a barrier to fentanyl initiation. Just a few years ago, it was the people who were using heroin did it at fentanyl. Now with the pills, you pop a pretty little pill and that's it. You don't need to inject to take a possibly deadly dose of the drug. And smoking and snorting are also popular routes of administration now. And I'll show you a figure showing some results of that soon. More experienced opioid users, pills sometimes are in fact too weak. Because if it does have less than 2 milligrams, someone might want a much higher dose. So in that case, powder would be preferred by somebody like that usually. Although some pills are very strong, so injection is not always necessary, even if you have a high tolerance. Or you could take a couple of pills instead of just one. And injection is also complicated by a couple of things with respect to pills. So there's the filler in pills. A lot of us forget that whenever you get a pill, the majority of it is just crap. It's nothing. It doesn't do anything. But that's not the type of stuff you want to inject. It's harder to liquefy. You have to sit there and liquefy a pill to inject. You'd probably just rather have the powder. And you have to inject fentanyl more frequently. If you use something like heroin every day and you move on to fentanyl, you have to inject fentanyl much more often. So you have to keep repeating the process. It's burdensome. So it's a difficult situation for a lot of people. So injection, another thing I want to point out is that injection is not necessarily an indicator of drug use severity anymore, because if it's that strong, you don't have to say, well, do you inject, yes or no? Now it's just, do you use fentanyl, yes or no, regardless of the route of administration. And these are all things I wish we had hard data on. These are things I'm hearing from people in national meetings, but I don't have the data. I wish I did, but we don't. And this is from poison control. The main line I want to show you here is the blue line of people who were poisoned and their data were reported to poison control. What percentage of people said they inhaled? And you see it went up about 428%. More and more people are inhaling fentanyl now compared to other routes. And part of the issue with this is interpretation. We don't know if they smoked it, sniffed it. It's just listed as intranasal, so or something vague like that. But we're not sure of the exact route of administration. So that's a limitation. Anyway, heroin is something else I want to talk about very briefly. Sorry I'm talking so fast, but we started late. I'm keeping an eye on the time. So heroin, as we all know, heroin did have fentanyl in it. Most of it, if not all of it, had fentanyl popping up for years. And a lot of people who were using heroin either intentionally or unintentionally moved on to fentanyl. And a lot of people just started preferring it. It's stronger. And heroin, I've been arguing, is largely a drug of the past. We don't see it as much. It's not as deadly as fentanyl. And here, comparing 2019 through 2022, the number of seizures, comparing, heroin to fentanyl. Heroin is the light pink and fentanyl is the dark pink. You see, just in 2019, there are a lot more kilograms of heroin seized. And it starts going down every year. By 2021, fentanyl seizures much higher. And 2022 preliminary data, it almost looks exponentially higher. It's changed a lot. So now fentanyl is clearly dominating the whole opioid situation. So heroin is largely a drug of the past, in the United States anyway. I don't think that applies to other areas so much. And I want to briefly just show you some state level counts. I'll show you why I prefer not to be a great public health person to present rates in this manner, but I'll mention that in a second. So the total weight of seizures in kilograms, that's pills and powder combined. So the darker it is, the more weight that was seized. California, Arizona, Colorado, the highest amount, over 1,000 kilograms within that year, which is, I think, 2021. But when you convert it to rates, you see obviously it looks a lot different. Anything you convert to rates is going to look different at the state level. But New Mexico and West Virginia are actually the highest. But my argument against rates here is that we don't know where the drug is supposed to wind up. So are we really going to do how many seizures per population when it just so happened to be seized in a particular state? Really, was all that fentanyl meant to stay here in like Arizona? No, it was, somebody was caught in Arizona. So am I really going to say, oh, well, the rate per people who live in Arizona is this? Well, to me, it just sounds a little weird. Yes, I present it sometimes, but I prefer to focus on the raw counts and raw weights when possible. And I'll show you a kind of weird example in a couple of slides why that could be a little tricky. So with regard to powder seizures, this is just, was it in powder form, yes or no? And here on the left, Florida has the highest number, and Ohio, West Virginia also. So that's the highest weight. And yes, Florida is big, it has a ton of people, I get it. And California has the highest total weight of powder seized. Oh, total number, and here's the total powder. California, right here where we are today, highest weight of powder seized. And with regard to pill seizures, it's a little bit different. Arizona has the highest number of pill seizures and individual pill seized. So not just was there a seizure, yes or no, but how many individual pills. And that also comes back to Arizona being the highest, over 5 million listed there. And it gets a little tricky coding these when things are so severely skewed. But back to the rates. This is the rate of number of pills. Because when I read the news, they want to try and make a point, this seizure was enough to kill like the whole state or something like that. So I'm like, all right, that makes a little sense, assuming it was supposed to stay in that state. It's not like, okay, this batch is meant for people who live in Arizona. But anyway, the rate here, it's almost 75,000 over 100,000. So the rates at this point, sadly, are starting to get a little ridiculous. It's not even a rate anymore, it's a percent. It's actually 75% when you look at it like that. What I'm worried about is when I get the 2022 data, is it going to turn into percentages instead of rates, which means it's becoming increasingly prevalent. So we need to keep our eye on this. But again, it doesn't mean we have to target communities as much within Arizona. That's just where the people were caught. I mean, for all I know, half of that was destined to go to, the East Coast. But I thought it was important to present briefly just a couple of the biggest seizures. So the largest powder seizures there on the left, as you see, the majority are in San Diego. It's closer to Mexico, so that makes sense. The biggest was over 2,000 pounds. I converted it to pounds because if you're like me, just American, I get confused with the kilogram. But yeah, you see a lot all in that area. And with regard to pills, a lot of them are in Arizona. And one seizure alone in Marion, Oregon was over 400,000 pills. But again, as I showed you a little while ago, there was a seizure of, what was it, 3.5 million just last month somewhere. So the seizures are getting much, much bigger. One thing I wanted to throw in here, I know we have a little bit of time left, was the trafficking and the possession situation. It's not something I focus on a lot, but with regards to criminal justice and social justice, things like that, it is of interest. So federal trafficking charges. So I know it could be different depending on like which state, city, but federally, the way we usually look at it is that 10 pills equals 1 gram, even of fentanyl, even if there's like less than 2 milligrams in a pill. So the way most, I guess, prosecutors, police departments do it is they weigh the whole pill. So if you get a pill that weighs like, just say, a full gram, and there's barely any fentanyl, they count that as a gram of fentanyl because it's the whole weight. It might be unfair, but it's just what they do. And so 10 pills typically equals a gram of fentanyl, and I've seen that a lot. So this is what 100 grams of powder fentanyl looks like. I wish they put something next to the baggie to see exactly how big it is, but it's kind of big for a drug, but it's not huge. But federally, if you get caught with between 40 and 399 grams of fentanyl, which, and I put the number of pills next to it, that could be a 5 to 40-year prison sentence. I'm not sure what the numbers are for sentencing when it's less than 40. It's not as severe. I don't know, maybe a lower level trafficking or possession. And when it gets more serious, that is when it's over 400 grams. And that's a lot. And that's over 4,000 pills in in one arrest situation. So I want to point that out, that we need to also keep an eye on how big these seizures are if we want to focus on criminal justice aspects. So I actually split it up according to different cutoffs. So how many were over a gram? The numbers increase. I like to look at here on the right at the proportion. The proportion, about 80%, and that's consistent across time, about 80% of fentanyl seizures have been over 1 gram. But that doesn't reach the 4 gram limit yet. The green line is 4, so that is widely considered the danger zone for trafficking. And yes, it went down a tad, but it's been hovering around 70%. So that means that a little less than 30%, maybe like a third of seizures are in that lower level situation. It's much more serious, the green line, and that's 2/3. That's a lot. So this isn't always just a low level possession. And the light blue line, 1 to 40, fine. But the very serious line, purple, and that is over 400 grams. And that is hovering around maybe about 15% or so. So we have some people who are like serious traffickers. I'm talking like large amounts. So that's just something I wanted to keep in mind about that. And relatedly, just legal outcomes. Unfortunately, we don't know the legal outcomes of people who were busted with fentanyl or other drugs. And that would be helpful to know. Too complicated. It could take years to track. And I hear that most seizures, I don't know what most means, whether it's 51% or 99%, resulted in an arrest. But I do want to mention that yes, NIDA, it's a law enforcement agency, but I have videos online of the head of NIDA, Tom Carr, testifying, I think it was Congress, and he was saying that, a lot of these people just need treatment. Yes, a lot of people are arrested, but it doesn't mean we want everybody to go to jail. We acknowledge that it's a big problem. But, remember, there has to be a limit. When someone's caught with 400 grams, that is another animal compared to being caught with a couple of grams for self-use. And yes, people are addicted, and maybe they get their money for their own fentanyl by selling it to their friends. But there has to be cut off somewhere that we have to figure out. 400 is a pretty big cutoff. Anyway, NIDA limitations. So as I've mentioned a few times, we don't know the final destination of where the drug is supposed to go. Just because we get a ton of seizures in this state right here, doesn't mean all of the fentanyl was supposed to wind up here in California. Fentanyl testing is a limitation. What a lot of these law enforcement agencies do is they find a powder. Yes, they want to test, is it meth, is it coke? But if it turns out positive for fentanyl or an analog at all, that also goes into the fentanyl pile. So if it's a pound of powder that says positive, that is also considered a pound of fentanyl, regardless of whatever else is in it. That has its positives, it has its negatives. Purity, that's related. but we don't know how pure the powder is. We don't know, is it pure fentanyl? Is there meth in it? Is there inert garbage in there? Combined drugs? It's all complicated. DEA data are better for that, but you'll never get your hands on it. And analogs, as I mentioned earlier, the analogs, the HIDA data, it's typically just, is it a fentanyl, yes or no? And yes, that's a limitation, we acknowledge that. And as I said, there's no data on people who are caught possessing. We don't know the racial breakdown, age, gender, anything like that. And we don't know if it was considered sales or possession when they were caught. And there's no data on arrest, sentencing, or treatment. I wish we had this, but we just don't. Maybe one day we could take a few steps forward to acquiring this information. And you see, just a few more minutes. I added in just a few more additional slides. I know we started late, but fentanyl is an adulterant in other drugs. I think we've known about this for years. It's been a common adulterant in heroin. Now most heroin contains fentanyl, at least in the United States. A lot of people prefer fentanyl. That's why I think heroin is becoming a drug of the past. Fentanyl, I say alarmingly, is now popping up in called a party drug, drugs like cocaine. And this is a big problem for the same reason it's a problem popping up in pills. A lot of cocaine use, most people who use cocaine are just people who use recreationally. There are probably a ton of people who go to this university who on Friday night, they're going to go to some bar, drink, maybe have a line of cocaine. It's part of life. And I'm not promoting it, but fine. But you have someone who's never used opioids, who goes to do a little bump of coke in the bar, and they could be carried out dead or carried to the hospital. There were rashes of these instances happening in New York City. So it seems particularly problematic where I live. And people argue, why would a dealer do that? He's trying to kill his clientele. Like, that's bullshit. No one's doing that. Like, yes, and sometimes it's an accident. You might have someone who sells drugs, was careless, mixed drugs by accident on the scale, something like that. No, there are people who are being interviewed by media, like by reporters, saying, oh, I thought it was a good idea to mix some fentanyl in it, because if they enjoy it, they'll keep coming back, they'll be addicted. Like, really? You're putting in cocaine? It's also popping up in meth, probably especially like on the West Coast. It's popped up in ketamine before. You never know what it will pop up in. And as we know, counterfeit pills, obviously, that's been a big problem. This is a sign that was put up in some bars throughout New York City, saying by the New York City Department of Health, warning people. I don't know if it's probably best in a bathroom. That's where a lot of people do cocaine. But just saying, like, warning, test your drug, be careful, be educated. You will never see stuff like this in clubs in the United States because of the Rape Act. So the main thing I complain about with Joe Biden is he wrote the Rape Act 20 years ago. It was originally called the Rape Act, reducing Americans' vulnerabilities to ecstasy. It was not passed. He renamed it and slid it into the Amber Alert Act of, I think it was 2003, 2004. And because of that, we're not allowed to do drug checking at any venue in the United States without fear of being arrested. It's related to Joe Biden's crack house laws of the 1980s. So that's a big problem. But things are changing because the United States is starting to warm up to checking a little despite the Rape Act. With regard to some of the EDM party attendees, I have been finding that knowledge that cocaine can be adulterated with fentanyl has been increasing. It's not perfect, but it's getting higher. So at least a lot of people in these high-risk scenes are at least starting to know that their drug can contain fentanyl. And yet, despite all this, all the education we're trying to give people, my main opponent has been Vice. So I've been quoted Vice probably about 20 times in the past how many years, but their main drug editor, who I think he's in the UK, he has been authoring all these pieces saying it's complete bullshit, that no one would ever put fentanyl in cocaine. It's not happening. In fact, at the end of 2022, dumbest drug scare stories, end of 2021, and one of them was that the drug supply has fentanyl in it now. And so stuff like this is clearly working against. We're spending our lives trying to educate people and save lives. And then one stupid article by Vice could, really change somebody's minds about that. Anyway, fentanyl test strips is really the way to go for people who insist on using. You could use that for anything. They're pretty available and they're very cheap. Anyway, did I finish on time? Yes, a few minutes to go. Sorry if I spoke very quickly. My main point of this whole presentation is that we need better surveillance. The crisis is going to continue to get worse. We need better surveillance. That's survey data. We all focus on that. Better death data, more timely data. And obviously we need to continue to educate. And I know people are going to keep denying that fentanyl's popping up in everything. It is, it's a big problem. We gotta keep our minds on what's going on. And one thing I want to mention here is that if you're interested in subscribing to our NDEWS weekly briefing, here's a QR code. And what we do with NDEWS every Friday morning, we send out a mass email to thousands of people listing some of the newest findings on drug monitoring, especially novel drugs, not just fentanyl. So that's that. If you have any questions about anything, feel free to drop me an email. And that's pretty much it. Thank you.
That was great. Yeah.
Thank you so much, Dr. Palamar. That was great. I think if the people in the room can stick around for a few minutes, I have a few questions online that I'd like to answer, or have answered by you, I should say. So the first is there data in regards to novice and proficient substance users, as well as a separation between mortality and survival rates?
No. So with regard to mortality in particular, we don't know because we can't interview them. So we don't know. I mean, somebody was trying to come up with a study recently. They were running ideas by me and some other people asking, could we do some sort of like a post-mortem situation, go back and interview the families of the decedents and figure out whatever information you can, how often they used, was it intentional? But again, we need such studies. We don't have them. So no, and we don't have any data really comparing novices versus experienced people with regard to fentanyl at all. Death data is the main thing we have, and we need more survey data, and no one's collecting it. I would love to, but NIDA would need to fund me, and they don't like me.
Yeah, it's like, I mean, there are people collecting data.
Yeah, but I was thinking more nationally, but
Well, I mean,
yeah.
we talked about.
Yeah.
Part of the problem with the national is there's not a national drug. market.
Yeah.
So, it's a unit of analysis,
Mhm.
is it meaningful, actually?
Yeah.
Well, it's just, look, in Los Angeles, there are at least 35 different places, there are at least 35 different, I'm not just making that number up, it's probably more. Intersections of geography, what is the drug you're using, what is the population that uses those drugs. So that's mostly what it means, is that it's spread out. So, and you have different patterns of different populations and age groups. Yeah.
That's an excellent point, yes, and you did make that excellent point in my office, so thank you. The thing I'm thinking of more monitoring, so when we have a national survey like Monitoring the Future, that's been going on since the 1970s, something that keeps going and going, that we could focus on various populations. If you get an R01 that's done in 5 or less years, most people take forever to publish if they publish anything at all. So things are just so lagged. With a more official monitoring system, even if it's local, well, we need that to keep going to alert the public quickly.
Yeah, I totally agree with you. But we just asked one other thing. So, because the national stuff will always matter more because we're stupid and we can't figure things out. One thing that would be interesting to hear what you think about is actually boosting up subsamples. So being intentional. So you're right, in the future, they're gonna get 6 people who report fentanyl. Well, if you had those 6 people, you knew where they were, let's do another 200 interviews around them so we can sort of try and figure out what's, if there's something bigger going on. And you're 100% right about how slow they are to change these things. Methamphetamine was a huge problem for a decade before they began adding questions to the National Household Survey.
Yeah.
Keep up the good work.
Yeah, they should do that. I've been trying to do that with my local New York City surveys, where certain people, just an in-person rapid survey, if they say, yes, they've used a particular drug, the recruiter gets an indicator, being like, invite this person to a follow-up, and we'll pay you, let's follow up on you, but, and you have to fund me or other people to do this. National surveys, to my knowledge, don't do this, unless it's a longitudinal survey, but they're not focusing on extensively on those couple of people at risk. So yeah, things need to change, and things are so slow. Yeah, thank you.
Does anyone else have a question? Just the mic is up. and about. There are a few more online. So another question is there any data on correlation to OD reversals by Narcan or naloxone?
I haven't seen studies. There might be, but I don't think so. I was focusing mainly look into how seizures relate to other variables, but I'm not sure. Probably not.
And we have a question from the UK. Can you speculate how the fentanyl crisis might end? And in your expert opinion, what would be the most important action to combat it over and above surveillance?
I don't know. I think very negatively. I don't see it ending, and that's that. I also said marijuana would never be legal, so I don't know. You can't listen to me. I'm not the authority on that. I do think that the trajectories are suggesting that the crisis is going to keep getting worse. And now, you know, we have more and more people initiating fentanyl who never would have used an opioid. So I don't know what's going to happen. It's not going to end that we all die, but it's going to keep getting worse. I don't know what could stop it.
And last question, are they checking for xylazine in the pogo powder?
I doubt it. I was thinking about that, and that's a new problem. And Philly in particular has been focusing on that a lot, but no, I don't think we have the data on that. It's hard to test for that. You have to know what you're doing. I mean, we can't even tell the difference between the analogs. You need more advanced testing to see what fentanyl analog is it. Xylazine, again, it's a whole nother animal.
Can you explain what it is and just like a little bit of
Yeah.
backstory?
Xylazine, it's like a legal drug. It's like a tranquilizer. It's used for legit medical reasons, but people are now mixing it into other drugs. I guess it increases some sort of sensation or downer feeling. I don't recall, but it's not good, especially when it's used illicitly. It's combined with other drugs like fentanyl, and it's leading to a lot of overdoses or contributing, because you don't want to mix something like that with tranquilizer effects with an opioid. So it's like a synergy, I guess. So it's a very dangerous situation. People need to know what they're taking. Then again, people probably want it. So people need to know and then not take it after they know.
Any other questions in the room?
Thank you for this presentation. So you have personal experience with the misinformation and news sources, and what are you doing to combat it, or how can scientists combat that?
I almost never turn down media requests, so I get asked about fentanyl a lot. I love to point out sources like Vice. They will never quote me on it, but I like to point out situations in which like people think they know this, but they're wrong, and they need to know this and so on. But I don't know. I try my hardest to counter all the misinformation, and sometimes it just doesn't work. Yeah, and the media is going to publish whatever they want. Yeah, I'll talk to a reporter like that Vice type of reporter, and I will say, no, this is not correct. And what drove me nuts is that they left me out. I was talking to him. He doesn't quote me. He found somebody that supported what he had to say.
Mhm.
And of all people, it was somebody that we all know, a well-known fentanyl researcher in the United States, that quoted saying, yeah, I have my doubts about the cocaine with fentanyl too. And I got really annoyed. You have a top fentanyl researcher taking their side. Meanwhile, people are dying in my city. The case reports are published. Fentanyl. So I try and counter it, but it depends on the reporter. It depends on their political agenda also. at least most people want to get honest information out there about fentanyl, but some don't. And another thing is, when you want to say how bad the situation is, when it comes into the whole legalization situation, you might have somebody that doesn't like when you're talking about the large fentanyl seizures and so on. Right away, the first thing a lot of people will say is, oh, you can't arrest your way out of it. Why the seizures even matter? You need safe injection rooms. Yes, I understand, but seizures have their part also. So I think we all need to learn how to talk to one another without just putting politics first. And that's a big problem. Everybody's putting their politics first. And it's very hard to have just a nice sit down discussion about anything. It's like, we're all trying to save people's lives here. Even if I fully support the whole seizure situation, fine, we're both on the same side. Stop arguing. We're trying to save lives.
Thank you again.
Okay.
Great talk.
Thank you.